Good evening, everyone. My name is Carolyn Brown, and I'm the Senior Associate Director of Development and Community Engagement at Penn Medicine's Basser Center. On behalf of the Basser Center, I would like to welcome you to tonight's panel discussion, Men and BRCA. The opinions and experiences shared tonight are the panelists' own and do not represent those of the Basser Center or Penn Medicine. You should consult with your healthcare team should you have any questions about the specifics of your health and medical plan. Thank you to our panelists for joining us this evening for this important discussion about men and BRCA gene mutations, including risk factors and surveillance options. Louis Abrams, who will be moderating our panel this evening, is an in-house attorney at a financial services company in Philadelphia, where he currently resides with his wife, Jenny, son, Maxwell, and dog, Pierre. In 2019, Louis learned that he carried a BRCA2 mutation. This diagnosis came after Louis lost his older sister, Marion, to BRCA-related breast cancer. Since then, Louis has been dedicated to raising money for BRCA-related research in conjunction with the Basser Center's Young Leadership Council. And with that, I'd like to turn it over to Louis.
Thank you, Carolyn. I'd like to thank our panelists for being here and offering their time on this important topic. I'd like to thank everyone who's attending this event. I'm going to start by introducing our panel. We have Dr. Vivek Narayan. He's an assistant professor of medicine in the Division of Medical Oncology at the University of Pennsylvania's Abrams Cancer Center. His clinical research interests are specifically focused on the care of patients with advanced prostate and kidney cancers. He participates in the care of patients with hereditary predispositions to prostate cancer and serves as a principal investigator for numerous therapeutic clinical trials, including novel approaches for Brca-associated prostate cancer. Next, we have Avi Anantharajah. He's a genetic counselor at the Basser Center for BRCA. He's a native of Toronto. Avi received his BS in microbiology and immunology from McGill University in 2017. He moved to Philadelphia in 2019 to complete his MS in genetic counseling at Penn, and he is a member of the Basser Center's Young Leadership Council. And last, we have Gary Fuhrman, Chairman and Chief Executive Officer of GF Capital Management and Advisors, LLC, a New York-based merchant banking firm founded in 2001. GF Capital Management makes principal investments in operating companies, particularly in the media and consumer product sectors. Gary is a breast cancer survivor with BRCA-related cancers and a number of relatives. He has the BRCA2 mutation and feels strongly that the story of male breast cancer needs to be told. Gary will talk about his experience advocating for himself to gain knowledge and lower his risk. Gary graduated from the Wharton School of the University of Pennsylvania with a BS in economics. And Gary is in New York right now, but he is Philly born and bred. So I just learned that. I want to thank you all for joining this evening. There's going to be a Q&A panel about 10 minutes before 8. Questions can be typed directly into the chat feature and we'll get as many as we can. So Gary, I'm going to start with you. Can you speak to your experience of being a male BRCA mutation carrier, including how did you learn of your BRCA mutation status?
Sure. I, believe it or not, learned that I would carry the BRCA gene literally when I was being wheeled into surgery for a double mastectomy. I had no idea, and my doctor said, it all makes sense now. You know, the pieces fit together. You're BRCA positive. That's why we are where we are. So I was quite shocked, felt awful because I was very vigilant, you know, with my healthcare. Had other cancers several years before and was always, you know, going to doctors, checking myself. And this just came out of left field. And I particularly felt, you know, really awful that I wasn't tested because my brother's a surgical oncologist. My mother had breast cancer. My father had prostate cancer. I'm an Ashkenazi Jew on both sides. And so, you know, for me, you know, it really was a wake-up call. And that's why I was so thrilled to get involved when I learned what Mindy and John Gray were doing together with Mindy's sister, Shari, and her brother-in-law, Len, and the kind of dream team that Susan Domchek, who I've known and respected for years, were putting together, it just spoke to me. I was compelled to really get involved and advocate for men, notwithstanding that I'm incredibly private, and I would never have imagined, being in a situation like this, talking about something so deeply personal. So, here I am, and, want to do my best, because it's not only for all the people on the panel, oneself, but it's also your children. And, God forbid you don't get tested and, you second guess what I could have done, should have done. It's just an awful feeling that no one wants to really, have. So I, really feel passionately, and I'm perfectly happy, notwithstanding I'm out of my comfort zone, to be on a microphone and do whatever I can, and honored to be involved.
Yeah, thank you. And I think it is, you're up here and you're sharing your personal medical adventure. So we really appreciate what you're saying. I wonder if you could speak briefly, and to the extent you're comfortable, about one, the mastectomy, just treatment and your general experience, and then two, what sort of screening measures and health measures are you taking now? Right.
Well, right. And I would just step back to say that, I, found this mass myself, from one day to the next. And, being a runner and working out most days, I felt something, that was off. And, I said, no, this can't be, and, the next day I sort of said, well, there's something there, it's not going away. And I, sort of sprung into action, and, sort of went and got, investigated. So, that's, how these things happen. You absolutely have to be your own advocate, because, these things can appear one day to the next, and, and you really have to check. And of course, men, not to go off on a tangent, men are not necessarily the best advocates. Women are typically the gatekeepers for healthcare in the family. And, men tend to avoid doctors and checkups, and even when they're feeling off. And I think that other than if it's orthopedics and it impacts their, sports regimen, I think so it's so important that men, advocate. And I think that the actual surgery, was, I got fired up for it. I said, here it is. My doctor told me I'm the only double mastectomy she's ever done. Now that's incredibly rare to have a double mastectomy, although, something like 2,500 men in the US, have it, it's typically single. So I, kind of got ready for it, and was prepared, and talked to, my sort of group of doctors and my brother, etc. And that was all fine. It was quite, the recuperation was not easy, but I was ready for it. What's more difficult is all the screening and all the things that you have to do after, because, the surgery comes and goes, and then, you get chemo, or you're on tamoxifen. And for me, I'm on tamoxifen which is a pill, which the doctors can explain better than me. And I'm on that for over a decade or more. So that's not the big deal. What is the big deal is not avoiding the things that you need to do to screen. So, yes, there's the screening of, prostate, there's the screening of pancreatic, and you have to go through all these tests, and, they're difficult because, it's the unknown. And, mine particularly was going through it during COVID. So I was wearing a mask, getting an MRI, and, you're in there for 20 minutes, and, it's quite unnerving. But you have to do it. And so, that's one of the things that really people need to understand, that you can't just say, okay, the surgery's done, I'm done. but also you can't let it consume your life. And that's really the journey I've been on the last couple of years, because this has been a couple of years for me, of how do I do what I need to do, but live my life and not be obsessed over every single test and screening I have to do, notwithstanding I have other things that I take care of on the blood side, you know, so with lymphoma. So that's the challenge. And, you know, as I say, hope is not a strategy. So you have to really, you know, lean into it and do those tests and do them when you can. You know, sometimes, you know, I'm going on vacation or I have a kids thing and I don't do it before because it's too exhausting. And it's not like a crisis that you have to do it one day the next typically. So you just have to program it and get ready for it. And that's sort of what I do. But that's really the hardest part, is really living with it and screening and, you know, and, you know, frankly, talking about it, you know, makes it easier for me, you know, in these kinds of settings.
Yeah, I appreciate that. And a lot of what you said resonated with, you know, with my story. I'm a BRCA2, I have a BRCA2 mutation. My sister passed away from a BRCA2 related breast cancer. I wasn't even aware of this mutation until she got her genetic testing done when she was diagnosed. Then she passed. And then I was reluctant to go get tested. And I think this is something we're going to get to. In this panel today, we're going to get with Dr. Narayan, is going to talk about, you know, some of the risk, and Avi's going to talk about getting tested and some of the counseling. But I was reluctant to get tested. I think there were two reasons, and I hope, you know, we could talk about today. One is the risk felt negligible to me, and I was very misguided. But it felt negligible when you see the stats as compared to BRCA-related cancers in women. And one, I think that was very misguided. And two, I started getting involved at the Vassar Center, even though I wasn't getting tested myself. And I really came to understand things like how severe, you know, the cancers can be. And obviously, I'm not a scientist or doctor, but that's, you know, I sort of understood the risks and really said to myself, I need to understand. And perhaps some of it was I was anxious about getting this diagnosis and how it would affect my life. And I have to do these screenings, but happy I did it. I wanted to spread awareness. Okay.
Right. I was just going to say that, you know, many people, you know, say, oh, well, it's my life. I'll do what I go to Dr. Not, but it isn't. It's your children. It's your, you know, spouse. It's your extended family. And to me, I just, you know, I don't see any reason, you know, it's a personal choice, but if you ask me, anybody that does ask me, and I talk to a lot of people about it, is, you know, testing is so important. And, you know, no one wants to look back and with regret that they didn't do that for themselves or for their families.
Absolutely. And I agree. And I think, you know, you could be in a situation where you could have taken preventative measures and had screening and find out when you could have done something before. So I'm glad I took control. I feel a lot better. I do screening, breast exam annually, skin check annually for melanoma, not yet a prostate screening, but you know, it's not too cumbersome at my age. It's just something I gotta stick to. So I appreciate your message. And I think, you know, I want to go to Dr. Narayan. We're talking about the reluctance to get testing, but I really want to focus in on what are the cancer risks for male BRCA mutation carriers? And if you can, differentiate between BRCA1 and BRCA2.
Yeah, thanks so much, Louis, and thanks to you and Gary for really sharing your stories. You know, sitting here listening to them as a provider, I think it really underscores just the power of the awareness of BRCA and the associated cancers and how it can really impact your health, but also the health of your loved ones. And so you asked about, you know, the specific risks with being a BRCA carrier status. And I think sort of the general point is that having a BRCA mutation carrier status can increase a relative lifetime risk of certain cancers. So for men, what we're really talking about is an increased relative risk of prostate cancer, male breast cancer, as in Gary's story, pancreas cancer. And I think that it certainly doesn't mean that all men who are carriers of these genes are going to develop one or more of these cancers, but I think it does mean that there is an increased relative lifetime risk of developing one or more of these cancers compared to the general population. And so I think one sort of general thought about this is that the risk depends on the cancer, the specific cancer of interest, but also, as you alluded to, the gene, so BRCA2 versus BRCA1. So in my world as a prostate cancer medical oncologist, I spend most of my time thinking about men with prostate cancer. And so maybe just to start there, with prostate cancer, the story with BRCA2, I think, is a little bit more clear, where we do know that, so first of all, prostate cancer is one of the most common cancers for men, at least here in the Western world. And, many men will develop prostate cancer irrespective of their underlying genetic, BRCA2 or 1 status. But having a BRCA2 mutation, we know from a number of different studies, there's an increased relative risk, a lifetime risk, and it can be up to 4 to 6-fold relative to the general population. And so to maybe put that in more discrete terms, in one of the largest prospective studies that have looked at the cancer incidence risk in BRCA2 patients, that sort of translates to about 60% of the male population by age 85 who have a BRCA2 mutation may develop incident prostate cancer. And I think the other important point about BRCA2 is that these cancers, when they do develop, can occur at a younger age and tend to be more aggressive prostate cancers than sort of the potential run-of-the-mill prostate cancer that may develop in the general population. I think with BRCA1, the data is a little bit less clear. However, I think sort of the preponderance of studies also indicate an elevated risk of prostate cancer, but not to the degree that we see with BRCA2. So again, in one of the sort of, I think, best done studies, they estimated at about a 2-fold increased risk relative to the general population. So, male breast cancer is overall.
Yeah. I was going to stop you right there if I could. So for BRCA2 carriers, you say a 4 to 6 increase, 4 to 6% increase in your chance of developing
4 to 6 times, no?
So
4 to 6 times.
And I think that actually raises a really important point, because it's we sort of think about risk, and I think it's important to think about both relative risk as well as absolute risk. And so, again, prostate cancer is relatively common. So, depending on sort of the population underlying, many men will get prostate cancer. So, some estimates are 1 in 7 men in their lifetime will get prostate cancer. But what I'm talking about here is a relative risk, so fold risk or times risk above that in men who are carrying a BRCA2 mutation.
Okay.
And so I think that is an important point.
Yeah, and I think, and you spoke about aggressive cancers, and I think really that's the thing that I keep in mind, and I think that these could be, you said younger, more aggressive, and it's all the more important to get screened. So I believe you were going to breast cancer and some of the risks there.
Yeah, so I mean, again, as a prostate cancer medical oncologist, I sort of spend most of my days thinking about urologic cancers, but certainly breast cancer, male breast cancer is a very important one in BRCA2 and 1 carriers. So, generally a less common cancer than prostate cancer, but still the studies tell us that a relative increased risk, so somewhere in about the 5 to 10%, lifetime incidence risk in BRCA2 carriers, probably less than 5% in BRCA1 carriers, still much greater than the general population for an otherwise relatively rare cancer in men. And then I'll just sort of finally mention pancreas cancer, which again, in a general population is very rare. So I think around 1%, but again, slightly higher in BRCA2 relative to BRCA1, but estimates in the 3 to 5% range for men with BRCA2, and then a little bit less than that with BRCA1.
And what about melanoma, sense of the statistics there?
Yeah, so I think, you alluded to this as a BRCA2 carrier, and I think there the story is, again, strongest for BRCA2, where there is a relative risk increase in melanoma incidence. Again, a relatively rare cancer, but probably in the 3 to 5% range in BRCA2 carriers.
Yeah, I appreciate that. And I'm watching the chat go by. There's a lot of specific questions about, sort of treatment and screening options. So I wonder if we could do just quick kind of parameters. These are going to depend on age and doctor, but if we could talk about screening option for men, and you could break it up by age, particularly for prostate cancer and prostate screenings.
Yeah, so for prostate cancer, I think the starting point is sort of talking about PSA. So I think anyone who's sort of read the news over the last 10 years knows there's a lot of controversy about PSA blood screening for men in the general population for prostate cancer. Of course, I have my biases as a prostate cancer physician, but I think most, including myself, believe in and use PSA screening, especially in higher risk populations such as BRCA carriers. And so, there have been some, I think, well done prospective studies of targeted PSA screening, specifically in BRCA carriers, so 2 and 1, in men in the 40 to 60 age range. So really the sort of prime population for identifying prostate cancer, hopefully at an earlier stage. And I think the take-home point from some of these well-done studies is that, again, primarily for BRCA2 carriers, the recommendations are to begin targeted annual screening with PSA beginning at the age of 40. And with men with BRCA1, again, the data is not as clear, but I would say consider strongly, or at least talk to your physicians about it as a BRCA1 carrier to think about PSA screening beginning at that age.
I appreciate that. And if we could go screening options, and again, I know your focus is prostate, but for breast cancer, and then if there is any for pancreatic, and then melanoma.
Yeah, so I think for male breast cancer, and I think Louis, you spoke to this a little bit, but again, the risk is highest in BRCA2, but the recommendation is for, first of all, just awareness of self-breast exam and sort of self-awareness of breast tissue in men, which is, sort of an odd thing for many men to think about, but I think is important to at least begin sort of examining and being familiar with breast tissue beginning in the 30s to 40s for most men with BRCA2 and 1. In terms of actual imaging screening, generally the consensus is for mammogram screening beginning at age 50 for men with BRCA mutations. And sort of different men can have different amounts of breast tissue. So something we call gynecomastia, or sort of more fatty breast tissue in men. And so, I think especially in those men with more breast tissue, I think the utility of those imaging exams can be more fruitful.
Louis, I just maybe want to say that I don't know what the statistics are, but I think the number of men that are actually getting mammograms is extremely low, notwithstanding their BRCA status, because I just know, the radiology community, at least in New York, and whenever I show up, they rarely see a man. And so I talk to them, radiologists. And so I don't know what the data is. First, you got to get tested, but then even when you get tested, how do you actually go? Because let me tell you, I've gone through it. It is unbelievably uncomfortable to, be manipulated on the machines and all these things. I mean, we should be very sympathetic to women. It is not an easy thing to go through. So, most men just don't do it.
Yeah, and I think, I appreciate that. So I guess, Dr. Narayan and Gary, I think you mentioned 50 years old. If you're BRCA2 mammogram, what's the, obviously we're using some tech, but could a doctor miss a cancer if they're not doing a mammogram, or is it less reliable?
So I think every test, so whether it's breast self-exam or mammogram or really MRI or any sort of imaging modality, certainly has test characteristics. So there's some extent of their sensitivity and specificity for finding underlying cancers. And I think that's true, unfortunately, of every screening test. Having said that, so MRI, is a different imaging modality that has some, unique test characteristics relative to a mammogram. And certainly in the female population, breast MRI is certainly used in certain high-risk populations. In my discussions with our breast oncologists and breast radiologists here at Penn, at least with men, because of the character of the breast tissue, and the varying degrees of the fatty content of the breast tissue, generally speaking, mammogram is the preferred test over MRI.
All right.
I can just attest to that. You know, when I first, sort of felt something, I went and, and was really, it was a male radiologist. He didn't do, he didn't do the mammogram, but he really just kind of, I would say, almost dismissed it. And I just, as I say, I skipped out saying, okay, I'm done. And then I said, no, something felt off. So I went back and saw a female, person that sort of really focuses on this. Turns out she went to Penn. Turns out I recognized her from Locust Walk, and she just gave me a totally different, perspective. And I saw in her eyes that it was something was, wrong from her perspective. And so I think it really does matter, and you've got to push, and you've got to, advocate for yourself.
Yeah, I appreciate that. And I think that raises, a couple points. One, I think, Gary, what you're really hitting on is the emotional components here. And some of these, you're mentioning you're the only male who's getting a mammogram. So again, I appreciate just speaking to that and, for us to consider it. I think it raises a question for me. I'm not sure if Dr. Narayan or Avi, anyone could answer, but if I don't know, let's say I got a genetic test and then I don't know what to do after that. I don't know what kind of doctor to see. I don't know if the doctor is going to be sophisticated in BRCA. What would you recommend for people? I mean, go to their primary care, go to an oncologist. That's sort of what would be the first steps. Obviously we have different geographies and situations, but any thoughts on that? I don't know if Dr. Narayan, you want to start on that?
Yeah, so I guess, so for someone who has a underlying cancer risk, right? So we're talking about predisposition, where do you start to sort of have these conversations? I think ideally this is really the power of having a medical genetics program that sort of has the infrastructure and the counseling, because these are not easy decisions, and there's sort of difficult conversations that happen as a part of this, the familial implications and so on. And so really having sort of a medical genetics program and infrastructure where you have the genetic counselor, you have the sort of urologists, surgeons, who sort of specialize in whatever organ system, biopsies and screening modalities. You have the medical oncologist to talk about things like, if it's getting to chemo prevention or whatever it may be, so I think it's multidisciplinary, I think. And so, whether it's sort of a program like Vassar or sort of other, similar programs is, I think, really probably the ideal starting point. Of course, having a strong primary care doctor as an advocate, I think universally that's so important.
Yeah, I appreciate that. And we're going to go to Avi to speak about the genetic counseling program. And I could say, as a preview, I got tested at Vassar by genetic testing and then spoke to genetic counselor and were amazing. And then just went to my primary care. So, but I recommend all the physicians at Vassar. One more thing. So to wrap up is there any screening for pancreatic cancer or?
Yes, I missed speaking about that, but so it's evolving. So the current recommendations for screening for pancreas cancer in BRCA1 and 2 carriers are at the age of 50 if there is a family history of a first-degree relative with pancreas cancer. So there's a lot of ifs there, but I think that's the sort of current consensus recommendations for screening for pancreas cancer. And in terms of modality, there's different ones. So there's MRI imaging of the pancreas, which can be used as a screening modality. There's also something called endoscopic ultrasound, which is a bit more invasive. It's a sort of scope into the upper part of the duodenum so they can visualize the pancreas. But it has the ability to really characterize certain pancreatic precursor lesions, and then also allow for tissue sampling if there is a suspicious area. And so, I think those are the modalities that are available for pancreas screening. I would just say that pancreas cancer is notoriously difficult to screen for. And so the real goal of pancreas cancer screening to be effective would be to identify early pancreas cancers when they are surgically resectable, and hopefully then translating to much more improved outcomes for an otherwise aggressive malignancy. And it can be difficult. It's, these precursor lesions, whether it's cystic, changes in the pancreas or small epithelial lesions, it can be, difficult or challenging to know what is concerning, what is not concerning. And so I think, here going to an experience center that, has the expertise in these sorts of screening modalities would be important.
I think that just having been screened, relatively recently, this is for men, I'd say the particularly unnerving one, because everybody knows the, survival rate is very low. Doing either procedure is involved. As I said, I did the MRI, and it's a very sort of tense, scenario. And I think, it's one that's easier not to do, but one that you must do. And so I would just say that's a particularly challenging one emotionally to get your arms around.
Yeah, I appreciate that. And then, Dr. Narayan, screening for melanoma. Is it skin checks? Anything else you recommend?
Yeah, so I really think, things honestly we all should be doing, proper skin checks, and then really preventative measures. So limiting time in the direct sun, wearing sun hats or shades, and using liberal sunscreen. I mean, I think all of those things are very important preventative measures for everyone, but I think regular skin exams for those at particular risk is, I think, important.
Yeah, I appreciate that. I know from my own experience, the things like, being more vigilant about sunscreen, and my primary care physician goes through with me everything that could be, raise your cancer risk, whether necessarily connected to BRCA or not, and mutations. And, I think about those, and I'm far more vigilant about my health, things like red meat. I don't know if there's a connection or not, but he said if there's a general increase in cancer risk, I'm cognizant of it. So this just reiterates the point, I think, of taking control of your health. And Avi, I want to go to you. So Dr. Narayan mentioned a genetic counseling program. What does that mean exactly? What do you do, and how does that complement what the providers do?
Yeah, generally, genetic counseling programs help provide support, whether that be through providing information or providing emotional support, or support through referrals for patients who are not only interested in getting genetic testing, but also, to your point earlier, Louis, for patients who have already received genetic testing and kind of need a handoff to physicians such as Dr. Narayan, who are familiar with hereditary cancer mutations, for example. And just to revisit the question of what if I don't know where to go, or what if I don't have a high volume center around me that I can go to or access easily. Thank you, Beth, for posting the website in the chat, but findageneticcounselor.nsgc.org is somewhere you can go if you wanted to see a genetic counselor who can do that handoff. There are other ways you can find a center, as Dr. Narayan said, that offers a medical genetics service. But now, especially with telehealth, it's kind of been a blessing that there is much more access to these types of genetic services that can be helpful for someone who's looking for a place to establish care.
I appreciate that. So I may start at a basic level with you. So what age do you recommend men get that genetic test? And I guess as a part B to that question, who should get a genetic test for BRCA mutations? Yeah,
that's a great question. I'll start with part A, and that's for individuals who have a known mutation in the family and are known to be at risk of having a BRCA mutation. When it comes to making personal screening decisions, having this information by the time you reach the age of 35 to 40 is useful. And that's because physical breast exams would start around the age of 35, and then prostate screening at 40. Now, some individuals may desire that information before 35 to 40. And a common reason is if they'd like that information before having children. Not everyone wants that info beforehand, but if they do desire that, then they can certainly get tested earlier. And so I think it depends really on who you're talking to, but 40 or earlier for the purposes of screening.
Okay, that's good to know. And I think Beth posted the link in the chat for genetic counselors. And Dr. Narayan, you touched on this idea that hopefully the physicians are sophisticated in this area, sophisticated enough. The handoff, Avi, you mentioned to a physician, would genetic counselors anywhere be sort of, up to speed in that area? So if I live, I don't know, California, and I want to go see a doctor in person, presumably the genetic counselors, would that be experienced, would be familiar with these doctors, have this expertise in this area.
Yeah, if they're at a center that offers genetic counseling, it's very likely that they also offer genetics services and oncology services, or that they can refer you to somewhere that is part of the service.
And so, when I got my test at Vassar, I met with a genetic counselor first, but I remember my head sort of spinning. Do you mind taking me through sort of your meeting with someone a man who just found out he has BRCA1 or 2 mutation, and sort of what sort of things are you advising? You mentioned emotional, talk about physicians, but what's sort of the gamut of what you're talking about with that person?
Yeah, and I mean, I think it can vary so much depending on who you're speaking with, and it's ultimately a lot, or all of the work isn't going to happen in that one conversation right there. And I think that's important to recognize. They've done a lot of studies on the psychological impact of genetic testing. And, patients come in at some type of baseline emotional level, and then receiving a positive result can change that. And then it takes some time to return back to that baseline. And so I think ultimately the important thing to do when you do receive a positive result is to take some time for yourself, and to really try and work through what your needs are. And I can say that as men, putting our needs first is not always intuitive. And also looking for support isn't something that's intuitive. And, I'd argue people talk about, I'll use Gary as an example. Sorry, Gary, but, sharing your medical history, and how that might make you vulnerable. I'd argue that not sharing those things may make us more vulnerable than sharing, because we may miss out on some important information for our health and for the health of our loved ones.
Yeah, I appreciate that.
I don't know if there's a difference. Sorry, there's a difference between, when men should get tested that, have, a parent that's carrying the mutation. My own perspective has been for my sons that, I will advocate that they get tested as soon as Susan Domchek tells me they should get tested, which I'm inclined to be earlier, because they are not, bearing children. They don't, have those same issues, and they should know. And, when I had my issues, we're totally transparent, so they're fully informed. We don't keep anything from their 17 and 18 years old.
Yeah, and I think the tide is, sorry, Dr. Narayan.
Just piggyback on what Gary just said. I mean, I think, these sort of screening guidelines, so age 50 for pancreas screening, or age, 50 for your mammogram or ultrasound, or whatever the sort of, age thresholds that are in these consensus guidelines. The big caveat to that is obviously every family history is a little bit different. And so, the sort of the caveat would be that, you can consider screening sometimes 10 years earlier than sort of the first degree relative who may have had the incident cancer that you're screening for. And so I think, just to sort of highlight that point that you make for your children.
Yeah, thank you.
Yeah, and in that same vein, in addition to a personal or family history that might change when someone would wish to get tested, I think the tide is also changing in that you don't need necessarily a reason other than you want to know to get tested earlier. You don't have to have a striking family history. You don't have to be having children. If you desire the information just for your own personal planning, then you should pursue it.
Yeah, I appreciate that, Avi. And Gary, mentioning kids, I have a 9-month old son. I think one day he's going to get tested, and I'm with you. I think the earlier he can, and he just, the knowledge is power. Even if it's just building healthier habits, even if he doesn't start some of these screenings yet at 25, I think that'll be a positive thing. But something that comes up a lot, and it's a difficult question, is we hear from family members who say, my daughter won't get tested and I want them to. Any advice? Obviously each family history is different, but any advice to offer to those parents, when we're talking about, let's say 35-year-old males, they're adults, they're on their own. It's difficult to compel them, but any strategies, successes, thoughts on that?
Yeah, I say this all the time when family members express that someone in the family, and we all have them, is reluctant to get testing. One is that genetic counseling doesn't equal genetic testing, or even going into talk with a medical professional about this doesn't mean that you're going in to get testing. You're learning and you're acquiring the information that you need to make an informed decision for yourself. And I think a lot of people who may be reluctant to get testing are also reluctant, or haven't put themselves kind of in front of either a medical professional or individuals who have mutations to kind of get the necessary information to be able to make an informed decision for themselves.
Yeah, and I guess to piggyback on that, just in general, what are you seeing that's stopping men from your perspective? And two, once men, well, I'll start there. What are you seeing from men that you think is stopping? You touched a little bit on it about hesitation with medical professionals.
Yeah, I mean, as Gary alluded to earlier, men aren't necessarily or historically the best advocates for our own health. But I think we have a great opportunity here. We've got an all-male panel talking about BRCA and male risks, and we've had a lot of interest and a lot of men joining the call. So I think the tide is shifting a little bit, and men learn from other men. As a young man who's slowly picking up little things that I'm noticing my father did, we have the opportunity to be good role models for the younger generation, and being an advocate for your own health is going to promote that for your loved ones.
Yeah, I appreciate that. And Gary, I think what sets the stigma, and do you think there's stigma here? Maybe less so on the prostate side, but we're talking about breast cancer, and you mentioned mammograms.
Oh,
what do you think that plays?
I mean,
yeah,
absolutely. I mean, it's I had always it was very much top of mind for me, because I saw my mother over many years and ultimately pass away from breast cancer. So I was very advocating, supporting, running for breast cancer. I did all of that. So it was deeply emotional for me. But I think, men sometimes are full of pride, and, and even for me, who do I tell, and I just ripped the Band-Aid off, because you know what, it's too important for me to worry about, my own, kind of privacy issues and whatnot. So I think it's really important. I think back to your question on a child that doesn't want to get tested, I think it also just depends on how the parents communicate, and and if they're super anxious and they're dictating what the kid should do versus embracing it as a family issue, which for us it really is. So I think it really depends. The parents can learn how to do it and get counseling on how to deal with that. Because I say, just putting your head in the sand, whether you're a parent or whether you're a child, is really, not a good thing. And I think as a parent, we all should want to advocate for our kids, and help them along.
Yeah, I think I appreciate that. And I guess, Dr. Narayan and Avi, feel free to step in. If there's people who say, I don't want to know, the knowing feels more emotionally damaging than whatever outcome I could say. If we just talk through the danger of doing that, particularly, and I'm talking about people who have potential family history, potential predisposition to something BRCA related.
Yeah, I feel like I deal with this every day. I mean, even just setting BRCA aside, just treating men with prostate cancer, you wouldn't believe the number of men we see every day who are sort of walking in with a very advanced stage of prostate cancer, who had symptoms sort of many years prior. And it was sort of this, unwillingness to sort of accept that, hey, maybe something's not right and I should get this checked out. And so, there's no doubt there's this, without making too many generalizations, but there's this concern about, men unwilling to sort of confront the realities of potential health. But I think what Avi said earlier is important, that, knowledge doesn't necessarily mean intervention in all cases, but it at least empowers the information to make the right choice for you and your family. And so I think that is sort of the message that should be delivered.
Yeah, and I appreciate that. And for just me thinking through that, I think it's a good point that let's say I'm healthy and I don't know, a 30, and just knowing this, it's not all of a sudden I'm going to be getting MRIs every 2 days. So just sort of the thinking and maybe situating people, I think even an appointment with a genetic counselor, I think maybe could go a long way with that. But we're running short on time. I want to, Dr. Narayan, if we could, to wrap up here before questions, can we talk about advancements in treatment, particularly prostate cancer? What advances are we seeing? Optimistic about anything?
Yeah, I mean, I think in the prostate cancer world, I would say we're catching up. I mean, the breast and ovarian cancer, at least in the world of BRCA, has been many years ahead of us in terms of developing a lot of novel therapies. But in prostate cancer, we're now learning from that experience and bringing those same therapies to the treatment of men with prostate. So, this is mainly, at least in the last few years, the sort of big category of drugs that are out there is a novel class called Parp Inhibitors, which, again, have been used in breast and ovarian cancer now for several years. And just in the last few years, we now have 2 FDA approvals for men with advanced prostate cancer using this class of drug called Parp Inhibitors. So these are generally pill therapies and taken once or twice a day, depending on the medication. And they target a underlying sort of biologic vulnerability that is present in men who harbor a BRCA mutation in their cancer. And so these medicines, at least at this point, are effective. They help to prolong survival for men with prostate cancer with these mutations, but at least currently they're reserved for use in the very sort of late or advanced stages of prostate cancer. And so the current questions are, how could we do better? How can we bring those medicines earlier in the treatment course of prostate cancer, perhaps then leading to greater bang for the buck, so to speak, with these agents? How do we layer them on top of other therapies that they may be synergistic with to improve outcomes with prostate cancer? And then I think the sort of next question will be, how can we use them around the time of things like prostate surgery or prostate radiation therapy, with the goal of hopefully curing more men with localized prostate cancer so that we don't develop the late stages of the disease to begin with.
I appreciate that. And for breast, I'm going to categorize breast, pancreatic, melanoma. Does their treatments generally vary from men to women, or, are they similar to your knowledge?
So for pancreas cancer, no, I think that, they're the standard therapies that are used, whether it's chemotherapy, immunotherapy, or things like Parp inhibitors in the sort of relevant patients, is independent of whether it's a man or a woman with the disease. Breast cancer is a little bit different. And I think, again, not being a breast oncologist, but there's a scarcity of literature for male breast cancer in terms of what is the highest level evidence for the disease. To my knowledge, there's not, the way that there is for certain women with breast cancer and sort of, chemo prevention strategies and such, there's not the same level of evidence thus far for men, but perhaps that will change.
appreciate that. And pancreatic and melanoma, if you could talk briefly about treatment strategies for those.
Yeah, so at least in relation to BRCA, I think with pancreas cancer, for melanoma, I don't think there's much different at this point, unless there is for the clinical trial. And we've had those sorts of patients on clinical trials where we've used things like Parp inhibitors or Parp inhibitor combinations. But for pancreas cancer, I don't think there's any difference between men and women. Parp inhibitors are used in the treatment of the disease, including in patients who have had hopefully curative intent surgery for pancreas cancer, but then using in the post-operative setting to try to reduce the risk of cancer recurring.
I appreciate that. So I see we're getting the chat is hopping here. So before we go to questions, Avi, Gary, Dr. Narayan, thank you. Anything else you want to add? And if not, I'll ask Carolyn to start maybe some Q&A.
Thank you all. Dr. Narayan, can you talk a bit about Parp inhibitors and how they are used to treat BRCA-related cancers?
Yeah, so I think, beyond what we talked about with advanced prostate cancer, so definitely it's an area of active research right now. Beyond what I already said, I think the next frontier, at least in prostate cancer, is bringing it into earlier stages of disease in combination with other effective therapies. And then, I think, I don't know if there was a question in the chat, but there's always, sort of this question about, can these sorts of drugs be used as potential preventative measures in men or women who have an underlying cancer predisposition? And I think the sort of short answer to that question is we don't know. But I think one important point that will need to be considered is, if you're using something as a preventative strategy, it's for long-term use. Of course, you want to be very careful about long-term side effects of medicines. And so we are generating that data as time goes on with Parp inhibitors, mainly from the breast cancer literature where these drugs have been used for now many years. And so some of the earlier trials where these medicines are used earlier, that sort of longer term safety data is coming out. And I think that will help to inform, what are the potential uses of these medicines as preventative strategies or at other earlier phases of the disease.
Great, thank you. And can you talk about treatments for metastatic BRCA cancer?
Yeah, so I think, across all of these different cancers, so breast, prostate, ovarian in women, pancreas, now we've had therapeutic approvals of Parp inhibitors for BRCA-related patients, but there's other medicines, that I think are, increasingly thought about. So again, as a prostate cancer doctor, just to give an example, we do sometimes use chemotherapy in the treatment of men with advanced prostate cancers, but we would never use typically a class of chemotherapy, something called platinum agents, at least in prostate cancer, mainly because it didn't work, when the studies were done many years ago. But we knew from ovarian literature, from breast cancer literature, that where they do use these platinum agents, that it can be effective, particularly in patients with BRCA mutations. And so, now that is increasingly used in men with advanced prostate cancer, and now has even made it into sort of our national treatment guidelines for advanced prostate cancer, where, you could strongly consider using platinum chemotherapy in men with advanced or metastatic prostate cancer. And so we're learning it's not just Parp inhibitors, but other, treatment modalities that can be thought of in these patients.
Great, thank you. And Avi, can you please address 23andMe and other direct-to-consumer testing?
23andMe testing, I saw there's some questions there in the chat. Test for 3 specific mutations that are primarily found in the Ashkenazi Jewish population. They do not test for others. And so it's possible, actually very possible, especially if you're not of Ashkenazi Jewish descent, that these types of tests could be missing a BRCA mutation, which is why we'd recommend that you go to a clinical service. There are other what are called consumer-initiated services, such as color, that do involve a health or genetics professional with their testing. But I would certainly take a look at some of the resources in the chat. I know Peggy, thank you, Peggy. She shared the Share It Genetics email, but kind of when in doubt, go to a clinical service. And there are also other direct-to-consumer third-party variant interpretations. I won't even go there, but there's kind of a black box, and clinical services are in general preferred.
Thank you. And we did receive a question about, should young men get life insurance before being tested for a BRCA mutation? Can you please address that? Yeah,
so in short, because not everyone ends up getting life insurance anyways, but if you were considering getting life insurance, because life insurance is not a protected area under the Genetic Information Non-Discrimination Act, which protects health insurers from using genetic test results to impact coverage eligibility and pricing of policies. Because life insurance doesn't fall under that protection, you may wish to purchase a life insurance policy before getting testing if it's something you were considering doing anyways. If it's not something you were considering doing, it does not have to be a barrier to getting your genetic testing. We do have BRCA carriers that were able to get policies. It's possible that it might be more of a shopping process or that it may be more expensive, but genetic testing can be used as a time at the very least to consider whether or not you'd want to purchase a policy.
Thank you. And the last question, how close are we to being able to surveil for all BRCA-related cancers through liquid biopsies?
And try and tackle that one. So the whole, I think, concept of using liquid biopsies. So for those who may not be familiar with the term, obviously a biopsy is an invasive sampling of some tissue specimen to look for things like cancer. So could we use testing of the peripheral blood, so what's circulating in our veins, to potentially identify underlying illnesses? And so it's a very, I would say, rapidly evolving field of cancer medicine in particular. There's different ways of looking for things. So, there's things like circulating tumor cells, circulating DNA. At least in the world of early cancer screening, I think there's still a lot to be done to sort of bring that to prime time. There are some earlier tests that have been done to look at certain commercial platforms to try and do this, but I'm not aware of anything at this point that I think is ready for sort of widespread use, especially in a BRCA population.
I think that's good for this evening. We know the chat has been very active and we love the conversation. Thank you again to all of our panelists for joining us this evening. We do recommend that you connect with a medical provider to discuss your particular risks and recommendations, and of course, reach out to the Baxter Center to help you and your family.
Thank you. Well, again, I appreciate the panelists' time. I appreciate the active conversation and everyone who helped set this up. And I might put my email in the chat, and feel free to contact me, and if anyone else wants to do the same.